All right, so let's talk about personnel radiation protection. So here's an overview. I will talk a little bit about some general stuff, things that relate to all of us in terms of protecting ourselves from this stuff. We'll go through some image protocols as well as things specific to personnel protection in X-ray, in fluoro, in nuclear medicine, and then, I'm sorry, radiation therapy, but y'all got cut off by my program. Y'all are on here, though. Y'all are in the mystery section, okay? That stinks. So here's some protocols that, in general, these two things are significant to every imaging department on the face of the planet Earth, especially if they're in the United States of America. We have to take measures to ensure that our equipment, whatever that equipment is, operates safely to protect patients, personnel, and the general public. And then any kind of imaging examination room or radiation therapy treatment vault, as well as all the devices, need to be designed to reduce patient and occupational radiation dose. This seems very, very simple, right? I mean, almost overly simplistic, but these are important things to be mindful of. I should point out, don't take this stuff for granted. There are facilities out there that find that these are advantageous areas to cut corners, right? And so we'll talk about some things to know and ways to test to make sure that this stuff's not being taken for granted. So in general, there will be some kind of control console for whatever equipment we're operating. And that control console will be behind an appropriate amount of shielding. So if we're dealing with diagnostic X-ray, I think it's like 1.5 feet of concrete, or like I think it's 1.5 centimeters of a lead equivalent, so that it shields us from secondary radiation. There'll also be some kind of elbow shape or something, either a door that you go in or something that allows you that while you're standing at that control console, you're not being exposed to anything more than background radiation. Also, there will be some kind of light or something that comes on to indicate when you're making an exposure. It will also make an audible sound, right? This is true in therapy and true in X-ray. That there will be a light and a sound anytime that you've energized that beam. For nuke med, y'all have a control area that y'all sit in, especially for PET CT. It's even thicker barrier, right? Because we're trying to shield from 511 keV photons. But your machine doesn't make any noises unless you're taking a CT scan, right? It just sits there quietly, and the patient's actually creating the radiation exposure. So we just have to be mindful not to get too close to that person for too long. We all aren't in the business of giving people hugs. In general, right, for all of us, we are going to have examination tables or radiation therapy treatment tables that are strong and can support the patient, but at the same time are pretty much radiolucent, right? We all know what that fancy word means. Radiolucent means that it's basically clear if you X-ray it. It's not going to show up too much on our... We don't want a table made out of like lead or something like that. We want a table made out of carbon. It should be of a uniform thickness, because especially in diagnostic X-ray, we would not want a tabletop that is showing up as uniform density changes, because that can influence our images. So I think the big takeaway here is a lot of times these tables are radiolucent. If you remember just what that word means, you're doing really good. For X-ray, now let's get down into the various modalities that we're practicing in and talk about specifically. Leakage radiation from the X-ray tube. If we measure it 1 meter away from that tube, it should not exceed 1 milligray in air per hour. So measured 1 meter from the tube, it should not exceed 1 milligray, right? And that's when it's operating at the highest tube voltage that could be operated at continuously. Now, they're not going to make an hour-long exposure with your X-ray equipment. The physicist will come in and make an exposure of some predetermined length, like 20 seconds, and then they'll extrapolate that out to an hour, right? They'll measure the leakage at a shorter exposure and then just lengthen that time out. But we've talked about how when we produce X-rays, they're produced isotropically in all directions, so we need to shield from any off-focus radiation. For X-ray, we will also have an SID indicator. And we've said that we may even be challenging this. We may be doing X-ray exposures at increased lengths in the near future as a way to reduce the patient's entrance skin exposure, as well as to improve our images. So sometimes we use lasers. Radiation therapy uses lasers all the time for SID indicators. And this is true for both therapy and X-ray. The distance and centering indicators must be accurate to within 2% and 1% of the SID respectively. So the distance must be within 2% and the centering indicators must be within 1% of whatever that size area is. So typically the way that they do this for X-rays, the SID measurement is they put the SID at like 100 centimeters, right? And then they make a measurement to see if the distance indicator is working correctly at that 100 centimeter distance, right? Why do they use 100 centimeters? Because it's that much easier to calculate 2% from 100, right? Very similar when they're doing that centering indicator, they will make a 10 centimeter square box and they are going to X-ray directly onto a flat plate ion chamber and they're going to see, is it incident with the area that we said it was within? Is it within that 10 centimeter square box by at least at most it can be no more than 1%. All right, so it has to be very, very accurate. Related to that is the collimation. So we can reduce, in X-ray, we can reduce exposure to both the patient and ourselves by collimating appropriately. Now, there are a lot of facilities out there who ask us to open the collimators open all the way, and sometimes that might be appropriate, but there are a lot of other times when we might want to collimate a little bit more. One thing to bear in mind with collimation is we don't want to over-collimate, especially if we're using a digital system, because that can throw the machine off. But on the whole, collimation will result in a significant reduction of dose to the patient as well as better pictures. Related to that is filtration. So filtration is some amount of aluminum equivalent, and we can see it's tied directly to the amount of energy of that X-ray beam. So I'm going to zoom in here a little bit. So in general, we're talking about 2.5 millimeter lead equivalent. Millimeter aluminum equivalent. 2.5 millimeter aluminum equivalent filtration for pretty much every diagnostic X-ray machine you will ever work on. That's total filtration. So inherent plus added filtration. Inherent filtration would be like the filtration just inherent in the machine, in the tube itself, plus some kind of added filtration. You don't sit there and add the filtration yourself. The X-ray tube is constructed that way. This is related in part to the same thing that the radiation therapists are doing when they use compensating wedges. They're shaping the X-ray beam using a wedge, using some amount of aluminum equivalent to reduce the X-ray beam down to some shaped pattern. And there's a wide variety of those. But the big takeaway here is that what we're getting rid of is the soft X-rays, the low energy X-rays. So we're hardening the beam. We are reducing the quantity of X-rays that are exiting the tube, but we're increasing the overall quality. And so largely what we're doing is getting rid of those X-rays that would just contribute to patient's skin dose. So it is a way to reduce the patient's skin dose as well as occupational dose due to backscatter. So again, we'll use aluminum because it effectively removes those low energy photons, and it's based on the half value layer of the energy, the diagnostic energy range of the machine. Half-value layer is the number one way that we can determine or define X-ray quality, is what is this photon's half-value layer. As the photon's half-value layer increases, so does the quality of that photon. And so this is a measurement that the X-ray, that our physicists, our health physicists will do once a year to determine, is the overall energy of the X-ray beam consistent with what's being said at the control console. It's typically expressed in millimeters of aluminum equivalent, and it's the best way to define beam quality is half-value layer. Okay, winding down with the X-ray stuff, we'll talk about reproducibility and linearity. And I've put these side by side. I know this is kind of a busy thing, but this is something that students struggle with quite a bit, is the difference between reproducibility and linearity. If you can imagine, reproducibility is just taking the same exposure over and over and over and over again. Same exposure over and over and over again. Each one of those exposures should be about 5%, exactly 5% of the previous exposure. So any exposure made at like 2.5 mass should be pretty much within 5% of each exposure at 2.5 mass. That's reproducibility. Linearity is what happens if we start messing with the MA and the time settings, but we're always going to shoot it at some amount. Like so, again, 2.5 mass, but that might be varying MAs or varying times. We want something that's fairly linear, right? And so when the settings are changed from one MA station to the next, but resulting in the same mass, the linearity should be about 10%. Shouldn't be more than that. Grids increase the patient dose, and they increase our dose also, but they increase image quality. Okay? So we've talked quite a bit about what grids are and how they work, but the big takeaway for radiation safety is that anytime we're using a grid, we're increasing patient dose, we're potentially increasing occupational exposure, but we're doing so to increase image quality. We're trying to get rid of scatter radiation. This is very, very important to the X-ray techs here, is knowing the SSD. People in radiation therapy talk about SSDs all day long, but it's the source to skin distance, right? And so for us in X-ray, anytime we're messing around with mobile radiography, the minimum would be 12 inches. And I don't think there's any facility that you've ever worked at that's shooting mobile X-rays at 12 inches, right? In general, we're talking about 40 inches, trying to get close to 72 for portable chests. So we want to keep those things within those things. Because as we bring the SSD closer to the patient, we are increasing the patient's skin exposure. We're also decreasing the image quality. Just because of magnification and things like that. All right, let's talk a little bit about fluoro. The things that we can do to decrease our occupational exposure and patient exposure when we're working with fluoroscopes is to use an intermittent or pulsed fluoro mode. It's fairly easy to toggle over to that. It does not typically affect the image quality all that much. As well as the last image hold feature. Most fluoroscopes that y'all work now probably already have the last image hold just kind of preset into it. But we used to actually have to manually tell it to do that. We want to decrease field size whenever possible. Time spent decreasing field size is good. It will actually clearly enhance your image, and it will reduce the patient's exposure as well as your exposure, because you're the one having to stand out there. And the weird thing about fluoroscopes is the primary area of backscatter radiation is going to be on the side of the X-ray tube. You would think that if you're standing on the side opposite the X-ray tube, where the X-ray tube is pointed right at you, that you would be getting the largest amount of dose. But that's not the case. With fluoroscope, it's the side of the X-ray tube that gets the primary dose, and that's largely from backscatter radiation from the patient. So again, we have SSD limitations. If for a stationary fluoroscope, and again, it's preset on those stationaries, but it shouldn't be closer than 15 inches. Anytime we're using a mobile C-arm unit, we should not get closer than 12 inches. As a rule of thumb, the best possible thing that you can do is bring the image intensifier as close as possible to the patient without contaminating a sterile field. Right? If you bring that image intensifier very, very close, just by obvious geometry, your tube will be as far away as possible if you're using a C-arm, and if you're in the stationary room, you'll just increase your image quality. In addition to that, we will have some kind of timing device. It is not the timing device is just telling us, hey, 5-minute reminder, you've hit 5 minutes of fluoro time, right? And that is, it's required on all fluoroscopic machines, but it is not actually tied to any kind of reporting. Like it doesn't say anywhere that the patient was exposed to over 5 minutes of fluoroscopic time. We can limit the exposure rate on fluoroscopes, and so there are different settings for that. So if you're trying to do extremity work, use the small exposure rate. It's a fairly easy thing to switch over. So in terms of our personnel protection from scatter radiation, we need at least a 2 millimeter lead equivalent for fluoroscopic units. They operate at a lower KVP than X-ray units, so the 2 millimeter lead equivalent will stop quite a bit of the photons from them, as well as a dead man switch type exposure switch, which means it cuts off if no one's standing on it. Okay, let's talk about nuclear medicine safety. One of the primary ways that we protect ourselves in the nuclear medicine department is how the facility is designed. So this is an image from our textbook showing the design of a PET-CT department, and the distance as well as the shielding between where the console, where the technologist sits, and the areas where the patient might be. Because now we've got this mobile patient who's basically like a little nuclear power plant walking all over the place and peeing on things, and everything that they do is creating some kind of radiation exposure. All right? Now, in addition to that, we probably need to continue to work on safety culture inside of the nuclear medicine department. And what that means is not becoming too lax on certain kinds of things, like, for example, using personal protective equipment when we're handling patients or starting IVs, as well as Kathy told me a story recently about a mammo technologist who came over and helped out in the nuclear medicine department, inadvertently contaminated their hand, and they had trailed contaminated radioisotopes all over the department and even got it on the gamma camera. And at that point, that camera is no longer useful as far as I understand because it's been contaminated, so we have to wait until whatever it's been contaminated with has gone away. So safety cultures in nuclear medicine might include having a Geiger counter that's always on and functioning so that we can hear if the contamination has occurred, sweeping our own hands after handling a patient, appropriately disposing of things, and also having trace posters and having those BERT discussions with patients prior to ever even walking into this facility. Because you can see even this person who's resting here in this room is creating a radiation exposure to the people in the room around them. So in terms of personnel equipment and ways that personnel who are working in nuclear medicine can reduce their radiation, personal protective equipment, so wearing appropriate gloves, when necessary wearing like a mask or something to prevent inhalation of airborne stuff. If necessary, using a fume hood. Do y'all use fumigation hoods at any of your departments? What isotopes do you use that for? The xenon. So if we're using something that is inhaled by a patient, we want to make sure we're not inhaling it, so we'll mess with that underneath the fumigation hood. We may use tongs or tweezers. We may use special like syringe extenders or things that can allow us to calculate a dose very closely while keeping it away from us. Syringe shields, which I know are not popular among nuclear medicine technologists, but they're always mentioned in every textbook, so I figured I would mention them here. They make the syringe very unwieldy, and so the dilemma now for the technologist is, okay, does this shielding shield me sufficiently to make up for the additional amount of time that I have to spend with the patient and with the radiation material since I have a shield in place? One of the things that I thought was interesting, I saw this in my reading, and I would imagine there's not a lot of facilities that are doing this, but if you're playing around with Tech 99, you can wear a lead shield. Do any of y'all wear lead shields while you're playing with tech? This is something that I saw recently in an ICRP report. If we are using technetium 99, we can wear a lead shield just like an X-ray tech wears a lead shield. So a 0.5 millimeter lead equivalent lead shield will protect you from a good amount of that technetium 99 annihilation radiation. So it's something that I would hope people start to have more as part of their conversation, that personal shielding when working with tech could actually decrease personnel exposure. And then the big thing for nuclear medicine people is minimizing the time that they're around the radioisotope and the patient once they've been injected with the radioisotope. So the safety procedures that we see in nuclear medicine, we talked about internal and internal contamination as well as internal dose calculations. So we do wipe tests with every time we have a delivery of this material. We do area monitoring. If there is a contamination, we will dispose of that waste separately from normal waste and allow it to go through 6 half-lives of decay or more. And then as we release the patients, we want to, again, reduce the amount of patient proximity that we have with those patients, as well as inform the patients, give them good education on reducing their proximity to other people, right? And we'll give them a specific amount of time that's related to the isotope that they've received, that they should minimize the amount being close to other people, right? So no hugs from their family, no people sitting on their laps or whatever if you're supposed to play Department Santa Claus or something, I don't know. All of these things is stuff they have to talk to their patients about. And you'll notice the release of the patients based on a maximum dose rate at 1 meter of less than 5 millisieverts. That's according to the ICRP. Is it different at y'all's facilities? How do y'all monitor patient release?
We pretty much let anyone go except like the monitor our I-131 patients.
Yeah.
And interview them, make sure that they're coherent enough and follow the rules. They can be sent home, but they have to be under a certain activity as well to be released.
Good, good. So the I-131, that's a therapeutic exposure to prevent hyperthyroidism or stop hyperthyroidism. Y'all are doing a similar thing anytime you're doing brachytherapy treatments in nuclear and radiation therapy. And so there will have to be part of the dose will be the physician's discharge orders, and it will be specific to that radioisotope when the patient can be released from the hospital. So for radiation therapy safety, again, facility design is probably the #1 thing that we are looking to for ways to protect personnel from this stuff. And what that looks like for the linear accelerator is a treatment vault, right? So we're going to have a corner here that has reinforced concrete, and as well as a door, like a 2-ton lead door that opens and closes very slowly, because we don't want the radiation to scatter and exit the treatment area, right? So everything's treated like a primary shield pretty much, and we have this little elbow or this little maze that they call it in the treatment vault, because the thinking is for the X-ray to get to where this door is at, it would have to scatter off of an air molecule or in some way bounce, so it would have lost some of its energy in that scatter event. It would not be able to get through that lead door. So facility design is something that's very specific to radiation therapy and a significant part of personnel radiation safety. I worked at a radiation therapy facility where like this corner, and I think maybe I've shared this with y'all, this corner of the vault allowed for some leakage of radiation. So there was this is where we sat. So here's our operator console where we would sit. And we always had to make sure not to tell our new students not to stand over here in this corner when we're doing radiation treatments, especially if we're treating in that direction, because it did have some amount of leakage radiation. They did monitor it. They had a film badge that they stuck on a memo board right there, and every month it measured some significant amount of radiation exposure in that area, but they had it monitored, and so it was within the requirements of all the health physics stuff, and it was okay. Now, in terms of additional ways that we protect the patients in radiation therapy, the plan for treatment has to be designed and approved by both the health physicist and the radiation oncologist. So before we ever even start treating the patient, they've had an extensive chance to plan out the treatment and to simulate the treatment and to make sure that it's going to deliver the dose to the best of our knowledge where we're saying that dose is going. Then we will fractionate that dose. So we're going to use what we know about radiation biology to divide up the dose to allow for the normal cells to heal between these huge amounts of radiation exposure. We're also going to limit the area of dose. So we're not going to give, very seldomly do we give whole body radiation treatments. That occasionally does happen, and I have participated in those. But in general, we're going to reduce the area down just to the area of the tumor and just treat that area. We will use image guidance, like we were talking about earlier. She mentioned port films. That's a way of guiding and making sure that we're treating the appropriate area. It's yet another way of protecting both ourselves and the patient. Make sure that we're delivering the dose where we say we're delivering it to. And then we will acknowledge certain dose limits. There's going to be dose limiting structures around that area. We would not want to treat past that dose limit because then we could run the risk of damaging healthy tissue. In addition to that, we can use white blood cell counts and red blood cell counts to monitor patients' radiation response. All right? So even with partial area irradiation, we may see decreased white blood cell counts. We may see decreased red blood cell counts. And there will be some threshold below which we will stop treatments. If the white blood cell count falls too low, we're running the risk of causing infection processes or anemia if the red blood cell count drops too low. So that's an additional way that we are monitoring dose and trying to be as safe as possible. We also do shielding evaluations. So I mentioned that they had to keep a radiation dosimeter there outside of that treatment vault. How did they know it was leaking radiation? Well, they did shielding evaluations where they go around with giant pieces of film and measure if there's any radiation coming out of that treatment vault whenever they make exposures. And then in addition to that, every morning the radiation treatment machine goes through a warm-up procedure and quality check as well as interlock checks. And so we make sure that, for example, the machine can't be operated when the door is open, or the machine cannot be operated if it's not aligned properly. There's all these different interlocks that have to be satisfied before we can turn that machine on. All right, and that's it for this lecture.